Good afternoon, folks. This is the subcommittee for House Bill 587. I'm calling the meeting to order at 1:05. The intent of House Bill 587 was to create a donor registry for anatomical gifts, if you will. Basically, if you are a resident of New Hampshire, that you could designate your organs to go to a preferred also resident of New Hampshire. That was the intent of the bill. What I also wanted to share with folks here today is the fact that I have some documents I emailed to you folks. I also have some documents that were shared with us from the organization is, oh, I gotta do that too?
Representative John said he's going to be about 10 minutes late.
Okay. That, are you my clerk?
No.
No. So there's some handouts I received via email prior to this meeting, along with a handout that came from the which organization?
New England Donor Services.
Thank you. So since the time this bill was introduced to literally a few days ago, there has been progress made at the federal level. And the federal government now has allowed, or will be allowing, CMS to open up what was considered to be a monopoly on the distribution or the assignment of organs, if you will, to open it up to what they call competitive marketing. So I wanted to talk to you folks here today is, given what's going on at the federal level and the fact that we don't know where the dust is going to settle on the federal law with what CMS is going to come out with for guidelines, what we should do with House Bill 587. We have three options before us. One, and again, these are all recommendations back to the full committee. We don't decide here. We only can make a recommendation back to our full committee. Option one, we can have ITL as a recommendation. Option two, ought to pass, and option three is interim study. Interim study basically means that over the summertime, we'll have another committee meeting talking about House Bill 587, what we should do going forward for the next legislative body. We can't bind that body. We can make a recommendation to the body about whether we want future legislation or not. So those are the three options we have on the table before us today. Interim study, ought to pass, or interim study. So I'll open it up to my colleagues around the table what your thoughts are as far as a recommendation of those three and why you'd want to support that recommendation.
All right. So before the federal law changed, I went and reviewed the testimony from last winter, and the testimony was pretty overwhelmingly opposed to this bill for a variety of reasons, one of which was, I mean, a lot of our transplants, if they don't happen at Dartmouth, they're going to be in Boston, and do we really want to get Massachusetts all upset and have them write a law, which then makes it harder for New Hampshire residents potentially? That was one of the arguments. I think the other one was that there were legal questions about whether this would be lawful at all. And then with the change in the federal law, I'm going, well, we don't even know what's going to happen now. And it seems that that at this point, we should just totally pause on this. So either ITL or interim study. I'll come back to the interim study. I mean, my personal feeling would be ITL, and then if down the road when the federal law is settled, people want to bring something back, they can. The question about interim study is if we do that, that would just apply to next year, and so I wonder if the federal rules will even be out to make an interim study useful.
Again, interim study, to be clear on the terminology, interim study basically means that we make a recommendation to our committee, then if it goes through the House that way, then it'd be another committee that would talk about what to do as next steps. And that would be whether to bring forward legislation or not bring forward legislation. That's basically the only thing that can be done at that point in time. To bring forward legislation requires another member of the legislative body in the subsequent session or term to bring forth that legislation. We can't bring it forth.
My first inclination would be to recommend committee ought to pass and let the whole house debate it, because since we worked on this bill in the spring, from testimonies it looked like everything is fine, but apparently UNOS and some other federal systems that were managing this organ procurement and distribution had some major problems that this bill can at least partially address. So I think the data which we saw this summer actually shows that there is some actual problems that this bill needs to address.
Thank you, Representative. Representative Flor. Representative Freitas, did you want to add any comments to this conversation? You're not here, okay. I do understand that Representative McDonald will be here in about 5 minutes, so we can take a slight pause until he gets here. So Representative Pelosia, how do you, can you say your last name again for me?
Polozov.
Pelosa, okay. President Pelosa, so your recommendation is to pass? Okay.
Yes.
And Representative Palmer, your recommendation is to
I would go ITL.
ITL, okay. Is there anyone in the audience that wants to address the committee before I go ahead?
Hi, good afternoon. My name is Sean Fitzpatrick. I'm Chief Public Affairs Officer at New England Donor Services. New England Donor Services is the organ procurement organization designated by the federal government to recover organs and tissues in the 6 New England states. So as such, we recover organs and work with around 200 different hospitals in New England. We understand the purpose from speaking to the Representative Cambrils, who wrote the legislation, was his concern that allocation changes in 2021 would negatively impact New Hampshire patients. And in an attempt to get in front of that issue, he wanted to keep New Hampshire organs close to home. Our view is, when you look at the data, that the system of allocating organs based on how long someone's been waiting, how sick they are, and how close they are to the donor is a significantly better way of allocating organs than had been done previously, which were based not on a 250-mile concentric circle around the donor, but based on archaic lines drawn by bureaucrats in Washington, D.C. So our view is it shouldn't be state by state. It should be patient by patient. We should have a patient-centric view of this. How long has the patient been waiting? How sick is the patient? How close is the patient to the donor? Those are the major factors, and not whether or not somebody is a resident of this state or that state. And as you mentioned, this would particularly hurt New Hampshire patients who the majority of whom get transplanted out of state. There are kidney patients who get transplanted out of state including, and then also every heart, liver, and lung patient has to be transplanted out of state because because Dartmouth doesn't do those transplants. To set up a system where it's state by state, and transplants, say, that take place in Massachusetts go first to Massachusetts residents would really hurt the entire New England area. And so I think that our view would be the current allocation system works for the patients of New Hampshire and that the data proves that. And then secondarily, there is the issue of federal preemption. We are a federally designated organ procurement organization. Dartmouth is a federally recognized transplant center. Neither of us can do anything that is off the list. That is, the federal OPTN runs a computer algorithm that tells us who the next patient is based on things like time waiting and sickness and body size. We must abide by the list, and the transplant center has to abide by the list. So even if this did pass, there probably wouldn't be any changes in New Hampshire because it would be preempted by federal law.
Thank you for that. Would you mind taking a second to help this committee understand, the subcommittee, the new federal law that was passed, the Securing the U.S. Organ Procurement and Transportation Network Act? How is that going to change things from your point of view?
There's been one organization called the United Network for Organ Sharing that has held the contract for a long time. The federal government is thinking that it is very hard for other contractors to apply for that contract because UNOS does so much at such a high level that really nobody has the expertise to come in and do exactly what they do. What the federal government is thinking is cutting up the duties of UNOS into, say, 5 different contracts, maybe a transportation contract, maybe a IT contract, a policy and development contract. In that way, maybe an IBM could bid for just the IT section of the contract and allow, say, UNOS to continue with the policy contract. So it's the most important thing they're doing is breaking up the contract. And then number 2, putting significantly more money into the system. I think UNOS is operating off of $7 million a year, and this new contractual system is going to be spending upwards of $70 million. So about 10 times more money is being put into the system to run it at the national level. But so there are likely to be, as we come along, some changes in the way policy is developed, and there might be some policy changes. I think the big issue going forward now, what you'll see with allocation is the 250-mile limit around the donor was a stopgap, because when you think of it, 250 miles is pretty arbitrary as well. What if there's someone really, really, really sick at 251 miles? So redoing the computer coding so it puts more emphasis on how close you are to the donor and how sick you are, and kind of leaving off the 250-mile line. And so that will probably be developed for kidneys probably in the next 18 months or so.
Members of the committee, any additional questions to the person doing the presentation right now? Thank you. I see a representative out in the audience. Would you like to say anything? Okay, just want to be sure. There's also some members, I think, maybe of the public. Would you like to make any comments? No. Okay. Representative McDonald, any thoughts about what you'd like to see this committee do?
Well, I was, first of all, my apologies for being late. I was detained, but I appreciate, Mr. Chairman, the emails that have been sent out and have been making their ways around. If this was covered earlier, I apologize for not being here. The email that came out about legislation that President Biden has signed, how does that impact this? Does it make it moot or?
That's the question before us.
Okay, all right. So that is not resolved yet.
No, I think the question that I see before this subcommittee of our committee is to make a recommendation back to the full committee.
Yes.
And my understanding is we have 3 recommendations that we could make. 1, ITL, 2, OTP, or 3, interim study. So I guess at this point in time, hopefully today we can come up with this subcommittee with some recommendation back to our full committee.
Okay. Sure.
A question to Chair. Is there another option to try to come, are we allowed to make some amendment to the bill?
Yes, you are. So if you desire to bring forth an amendment when we get into executive session, I will now defer to our chair. I believe at that point in time, in executive session, you can bring an amendment to the underlying bill, and then the committee, full committee, can vote on the amendment, and that amendment, if it passes, would then go into an ought to pass as amended.
Yes, that's correct.
That's after this goes back to the full HHS committee.
Correct. We could, so actually it's 4 options, because we could do OTP, and to Representative Yuri's comment, we could also do an OTP-A, a recommendation to the full committee that we could support the underlying bill if it was amended.
And again, yes, that's correct.
Yep. My thoughts on this is the fact that we do have federal preemption. And I think at this point in time, not knowing exactly what the federal government's going to do and how they're going to make changes on the underlying process, if you will, whether it's going to be multiple contracts funneled through one agency, or whether it's going to be multiple agencies, I don't really know. That's been clear. I think the intent is to have one policy, national policy, with different contractors working under the same policy. But it's not clear in the federal legislation that that is a mandate. It could be something which CMS is going to work on, and how they're going to work on that, I don't know. I think at this point in time, given the unknown of what's happening at the federal level, and the fact that we have federal preemption, I'm leaning towards more to ITL it, possibly to consider interim study. So maybe by next summer, we'll have more indication from the federal guidelines coming from CMS what their intent is. But right now, I think to act on something at this point in time is really premature.
Mr. Chairman? Another concern that's been expressed is New Hampshire is a very small state, and if we start being possessive of, protecting our own organs, if other states follow suit, we could be negatively impacted by that if a larger state were to follow that kind of policy. That's been expressed to me several times.
A question on, so what are the benefits of whether we will continue to work on this bill, or if we continue to work on this bill, can it be introduced again in next session, or like if we kill it now, like is there like a difference?
This is my take on it, but I will definitely defer to Chairman McDonald about the actual ins and outs of this. If it goes to interim study, then you'll have another bite at the apple with another group of our peers. I don't know if it comes from all of our committee members or if it comes from people within the House. At that point in time, they would work on exactly what we're doing now, have hearings, discuss it, and then next fall, after the election cycle, bring forth future legislation based upon the information that they obtained during the interim study committee meetings. Answer your question is, you can't really bring it forth in January, but you could have an opportunity during the summertime to have more discussion, bring together stakeholders, and based upon the conversation with the various stakeholders, is in subsequent year, which would be in 2025, 24, you could then bring forth legislation in LSR built upon what you learned.
Yeah, if we were to ITL it and the House followed our recommendation in January, the bill can't be brought back in the second year of the session. The same bill can't be brought back, so it'd have to either be a Senate bill, or as to Chairman Merchant's point, it would have to wait until 2025 in some form. Interim study bills also, basically the ultimate decision is to either recommend or not recommend for future legislation.
Thank you.
Representative Pelosi, are you looking at trying to bring something forward in a subsequent legislative body versus next legislative year? Because if we're looking to do something going forward, instead of just doing ITL, maybe the option would be an interim study, and then at that point in time, pull together stakeholders with the various stakeholder communities, and maybe you could be the chair, and at that point in time, through those discussions, come up with a recommendation back to the full House, basically saying either future legislation or no future legislation. But that may be, if you're really interested in trying to do something, a better option than strictly an ITL.
One thought I have is where it kind of comes down to a legal question based on the federal law that was just signed. Is that something the legal counsel of the House could help advise us on, perhaps?
That's a good point. So how do we do that?
Either myself or you could approach Attorney Cianci and see if he could render some kind of an opinion for the subcommittee to either consider or at least us, I don't know if you're planning to have another meeting or not, but whether we have another meeting or we just consider it, via email among the four of us and bring a recommendation to the full HHS committee based on Attorney Cianci's input. That would be a consideration, perhaps. I don't know if you want me to do that, or if you want to do that, or
If you would be so kind to
sure.
ask, it'd be fine. I think what I'm hearing is that we're looking at preemption based upon the underlying bill, which is 587, whether it would stand, or we're looking at something going forward
Right.
and saying, based upon what's happening at the federal level, at the state level, do we have any wiggle room, or is federal preemption going to basically shut down anything we want to do at the state level?
Right, and I can't speak obviously for Attorney Cianci. He may not feel comfortable rendering that kind of judgment, but we can, I'd be willing to ask him to feel that's appropriate.
Yes, I do. Thank you.
Right, I'll do that.
So do we have a motion on the floor?
A procedure question.
Sure.
If Chairman McDonald is going to ask that question, it's going to matter what we do, even if we ITL it, that's sort of then it becomes a moot point, right? So where I'm stuck is I really would be not willing to vote, want to pass for this, but if voting interim study gives us time to find out whether it's legal or not, then then I go along with that.
And you raise a really good point, Representative Palmer. Again, what we do today is only a recommendation back to the full committee. So we could, as a committee, come up with a recommendation, whatever that recommendation is. And then once we find out what's coming on with a legal opinion, bring that legal opinion back and still support our initial recommendation or change our recommendation at the time of the full committee.
Mr. Chair. Perhaps, and It's my understanding, this subcommittee, everything we do has to be public, as it is today. Perhaps we could have a quick subcommittee meeting, even the morning of the full, the full committee meeting, which will be probably late October or early November. The deadline for retained bills is November 17th. So perhaps we could have a quick one just based on Attorney Cianci's opinion and, make our official recommendation at that time, if that sounds good.
Yeah. Yeah. I do like that solution.
Okay.
Yep. You okay with that?
Yes, perfect.
So at this point in time, we're going to not come up with a recommendation. We're going to have a subsequent meeting before our next full committee meeting, which will be sometime at the call of the chair. Okay, now I'm going to look at the legislative assistant. How do I fill out this form that's before me? Because we're not making really a recommendation. We're going to postpone things until then. Hang on to it. Okay, thank you.
Nothing's ever easy.
So is there anything else we'd like to talk about today, or should we make a motion to adjourn? With that recommendation to meet prior to the full committee meeting in October, November at the college chair.
That's fine. I know of no other business to come before us unless the other members have something.
No? Oh, thank you. We'll adjourn the meeting and we'll reconvene at the prior to the next meeting at the call of the chair, 15, 20 minutes before that. So thank you.